Bonjour à toutes et à tous.
Good afternoon, everybody. We're going to begin. If you'd like to take your seats, please, because we have 4 prestigious presentations, and we need to make sure I don't get behind schedule. Thank you very much for taking part in this workshop on medical cannabis, which is going to be co-chaired with Nathalie Richard, who's Director of Medical Cannabis in the Drug Agency and the project in the French Drug and Medical Device Safety Agency. And we've been able to invite 4 speakers who are going to be talking to you more specifically, since this is a conference on addictology with a bit of psychiatry and dual pathologies and so on. These are things that we are always confronted with. We chose to talk specifically about troubles, use disorder and mental problems, not talk about all the potential applications of medical cannabis, which were already mentioned, I think, at this conference 4 years ago. They haven't changed very much in France. It's pain, it's epilepsy and so on, and other specific neurological disorders. After each paper, we will suggest that you ask your questions so that you're sure that you have time to ask all the speakers the questions that you have. We're going to start straight away. There are 3 in French and 1 in English. Looking for Nick. So I think that you have to choose channel 1 for French and 2 for English, or maybe it's the other way around. I think it's 1 for French and 2 for English, depending on which language you want. We'd like to first welcome the first speaker, Professor Florence VORSPAN, who is a psychiatrist, of medicine, and addictologist, and a professor at the University of Paris-Cité, and also works as an addictologist in the Parisian hospitals. And she coordinates the Institute of Research on Addictions, involving different bodies working on addiction in terms of research within this university. And we'll begin with you, Florence. Thank you. Good afternoon, everybody, and thank you very much, Professor AUTHIER and Professor Richard, for the invitation. Thank you. I'd like to thank also the organizers. It's always a pleasure to come to Biarritz and to come to this conference. And I've ticked a number of workshops that I'm going to be attending during these days, and it is a conference of very great quality. As Nicolas said, I work in the Parisian hospitals at Fernand Vidal in Paris. And I'm going to be talking about clinical trials testing cannabinoids in substance use disorders, except for cannabis, because you're going to have a specific paper on that just after this. And I've been working for a few weeks in a new responsibility, and that is coordinating several research teams from the medical faculties and the psychology faculty of Paris-Cité in this Institut hors des murs, it's extramural institute. What I'm going to be talking about today is mainly the scientific justification for going to test cannabinoids in a certain number of use disorders. The molecules that are studied, will see that most of the studies are on CBD, excluding cannabis, and see what are the methodological choices that the different researchers who designed these studies in terms of therapeutic targets have been. And then we'll finish with a discussion, and right at the end, I'll give you some ideas about a clinical trial that we're currently doing that I have been coordinating and is being done in several hospitals, including mine, using cannabidiol in alcohol use disorder amongst certain patients. So the scientific justification, this is a conference of addictology, so I don't need, I think, to go into details about the burden that addictions represent for the individuals, for their families, for the health system, for institutions, with a lot of death and morbidity connected with substance abuse and also access to healthcare. And we can say what we can say about the treatments and say whether they're efficient or not. Some areas are not covered, but even those treatments that we do have, it's not that easy to have access. For example, alcohol use disorder, about 80% of patients don't have access to treatments that do exist because they have insufficient access. So even when they do have access, the response levels are often disappointing for the most complex or severe patients. And so there are a certain number of complications in terms of use disorder or individual pathologies for which we don't have a therapeutical response. For example, no drug with market authorization or validated psychotherapy for a certain number of pathologies or subpathologies. So why do we have this idea of using a certain number of cannabinoid products to try and respond to these issues? Could be a very pragmatic attempt and say, after all, we don't have that many treatments for all pathologies. We know that there are psychotropic drugs. Users have been using cannabis since ancient times for its psychotropic effects. We know it goes through the brain-blood barrier, and the clinical results and clinical effects described by users and also in a certain number of scientific studies are effects that you could say they could be useful for patients suffering from addiction. Of course, the anxiolytic effect, but when you look in detail at the scientific literature on the anxiolytic effect of cannabinoids, the methodology is not always, at least in humans, ideal. Sometimes it's questionnaires that are sent to users who may be militant activists. You can have articles comparing cannabidiol, which can be anxiolytic with regard to ATHS, and that can sometimes increase anxiety. So the literature doesn't always rely on an absolutely perfect methodology, but you can see what the patients say, what users report. This is something which is reputed that there is an anxiolytic effect of these molecules. Effects on sleep, same thing. The methodologies are not always convincing. The good studies are beginning to emerge. And the effects on the ability of a certain number of cannabinoid products to lead to sleep or to prolong sleep, this is well known. But there's also the question of the effects of soothing the effects of stopping taking drugs. It's not that easy. The anti-epileptic effect has been demonstrated. There are market authorizations in the States and in Europe. And the antalgic effect, they're painkillers. That's one of the indications where we have good studies against placebo with indications that it can be effective. There's been a very recent study this year on back pain with THC and CBD extracts at fixed levels, fixed rates. The other justifications for using cannabinoid products to treat substance use disorder can be based on biology, what we know about the biology of the endocannabinoid system, because we have some products and some receptors which are in that family within our central nervous system, interacting with the opioidergic system. All of the articles in the literature, here's an article from Nature Reviews, Neuroscience. It's perhaps not very clear. You have to go and look at the publication. The system of reaction to stress and the system of the brain amygdala. So a lot of reasons to go and look at the effects of cannabinoids on substance use disorders, because patients that we encounter may have this kind of anxiety or hyperactivity and stress, sleep disorders. There's a whole range of symptoms that it looks like cannabinoid substances could ease. So the molecules that we've studied in the studies on substance use disorder, it's mainly cannabidiol in clinical trials, randomized against placebo trials. There are a certain number of trials for cannabis use disorders, it's used mixtures of cannabidiol and THC. So the pharmacological target are the endogenic receptors that we have, the cannabinoid 1 and cannabinoid 2 type receptors, for which the endogenic ligands produced by the brain are anandamide for CB1 and 2AG for the CB2. Once again, I'm going to be talking to you about studies on the use of cannabinoid products to ease substance use disorders, excluding cannabis, or symptoms which occur during substance use disorders. Of course, the literature is exponential. Every day there are new studies coming out. It's something which has benefited from the increasing use of medicinal cannabis, particularly in the United States, because before recreational cannabis was authorized in a certain number of states. So it's an area of scientific research which is a very dynamic one. And then you saw, if you go into town in France, you have an increasing number of specialized shops with some products using cannabidiol as a product, a general consumption product in preparations like teas, herbal teas, infusions, oils, or beauty products, and so on. So there is a dissemination and an increase in the research and the use of these products in the general population. And when you ask users of medical cannabis, and this has been done in a certain number of surveys, those that didn't have associated recreational use tended to prefer to use cannabidiol to products based on THC. So we have a certain number of arguments which can explain why cannabidiol is more often used in studies trying to assess the effectiveness in substance use disorder, with a rationale, which is that it is an agonist of the CB1 receptor, a low-level agonist. CB1 can sometimes cause depression, but a number of other properties that are not directly linked to the cannabidiol type 1 receptor. Probably a very interesting one is the agonist effect on what we call the TRPVs. Those are receptors which are on the endothelial cells, probably with effectiveness in terms of anti-inflammatory action, and then properties on the serotonic receptors. So not long ago, but everything happens so quickly in this area and things become outdated very quickly. But in 2021, a review of the literature was published of clinical trials of cannabidiol for substance use disorders, with a focus on what were the choices and the therapeutic targets chosen in these trials. This year, again, a review of reviews on cannabidiol in substance use disorders by Maria Melchior's team, and in September, a new review of trials using cannabidiol in opioid substance use disorder, with clinical studies with animals and some human trials. But I think we should look at this one, and this is the one we'd quote for our students. So if you don't want to read everything, I could maybe give you some of the key outcomes of these studies. When we look at the literature in substance use disorders, there are two kinds of studies. There are classic randomized studies where patients are randomized to receive, generally over a period of 12 weeks, very often as outpatients, double-blind, and compared to a placebo. They are given a product which is very often cannabidiol. When we did the review of literature in 2021, there were 0 trials in alcohol disorder, use disorder, 2 in cannabis use disorder, and we'll be talking about that just a bit later, and not very much. But there were a lot of studies which were controlled, randomized, which are methodologically well done, which were proof of concept studies, very short studies, generally 3 to 7 days, in which the subjects are not necessarily patients. Sometimes it's patients with use disorders, sometimes it's healthy subjects, have one single administration of the product or the placebo, sometimes repeated 3 or 5 times over a small number of days. But it doesn't actually, it's not a therapy for a disorder. It's more experimental psychology with crossovers. Well, it's blind when that's possible, or double blind, and compared to a placebo. It's methodologically well designed, but it's very short. In 2021, we didn't have studies in alcohol use disorder, 2 for tobacco, and 5 for cannabis use disorder. So not a lot at that stage. When you carry out a standard randomized study or trial over 12 weeks, what are the targets in these studies? Of course, the reduction of use or abstinence at the end of the study is very often the main goal. It's measured with retrospective questionnaires. We ask patients to report on their consumption. It's very often confirmed by objective tests, such as urine tests, and scales of craving, because reducing craving is probably a good indication of the ability to reduce consumption later on. In the proof of concept trials, it's much broader, and there you can have target symptoms or therapeutic targets. It could be craving tests induced in experimental circumstances, and we change scales. That can be questions of attentional bias towards the substance when the patient is suffering from a use disorder, scales of anxiety, cognitive tests. Once again, a single administration against placebo. Are we getting better or worse results to cognitive tests? Facial emotion recognition tests, which are an approximation of an antidepressive or anti-anxiolytic test that can screen molecules that could have this effect. And finally, the psychotomimetic effects, looking for secondary effects to check that the single administration or repeated once and twice of cannabidiol does not cause psychotic manifestations like THC can do. And even if it's only over a day or two, we try to see whether there is a potential for abuse with questionnaires. Did you like it? And they're asking the questionnaires in a scale from 1 to 10 with regard to the placebo. That was 2021. Of course, when you go to conferences, we try to update the bibliography, and we realized that it's a field which is extremely dynamic with a lot of new studies in 2025. And so I said there were 0 alcohol trials. Now there is a controlled randomized classical trial published in 2025, alcohol use disorder, 8 weeks, with 150 milligram capsules of CBD oil or placebo. And as a main criterion was reduction of consumption, and the trial was not positive. Cannabidiol was not more effective than the placebo. But this is something, the trials are coming out now. In the proof of concept controlled randomized trials, I have one which is quite amusing. It's a driving simulator to see whether cannabidiol compared with placebo could affect and disturb your driving skills, and a trial on opioid substance use disorder with an induced craving trial, which was interesting. It seems to show that cannabidiol, with regard to the placebo, with single administration can reduce the induced craving. There are 2 others, again, alcohol, with measurements of induced craving, but linked with functional studies in young people, rather abusers, rather than people who are dependent on alcohol, and 2 tests by the same team, placebo or administration of 800 milligrams of CBD with cognitive tasks to accomplish with functional IRM, and working on a task with induced craving, and looking for side effects, something I'm going to skip quite quickly because you're going to have a presentation on that subject. But all of this suggests that it is a field which is changing very rapidly. 2025 is the year where you need to read the trials that are just coming out, particularly in cannabidiol in substance use disorders, and finally trials on alcohol. We're still at the beginning of the controlled randomized trials of the classical kind. There's no proof of effectiveness yet, but there will probably be some therapeutic targets which are going to be designed with all these clinical trials. I think I still have 1 minute left. Just to say that we also have a trial which is being carried out with cannabidiol to end alcohol dependency. We're recruiting patients at the moment, 900 milligrams for 10 days. We give vitamins and other subjects, and either 450 milligrams or a placebo for 10 days. And I hope that I'll be able to come back soon with results in 1 or 2 years' time with the results of this trial. And I'd like to thank you and thank all the team that's behind me. Do you have any questions? Just before, I've got a little question. When we set up this presentation on medical use of cannabis, you auditioned with regard to the psychiatric uses that could progress. If we're at the beginning of the experimental phase, but you said at the time that there weren't enough elements to introduce this indication into the experiments. I think that's something you could comment on now. What are the major differences between these trials and experimentation of medical cannabis in France is that most often in trials there are the pills or tablets, but not products that are smoked. In the medical experiments, it's the flowers that are inhaled, it's not burning. There was this question, and I was very affirmative a few years ago, saying that we'll never have indications of smoked products. I maintain that, but now cannabis as in drug form, CBD or perhaps THC-CBD for certain indications, yes, I think that this is going to come. But there needs to be clarity about the simples and the symptoms and the durations, and perhaps again for some target symptoms such as anxiety and so on, or other things of that kind.
Thank you very much. I really enjoyed following your presentation. The last 3 slides went very fast, so maybe you could comment on the study with 900 milligrams CBD. First, what kind of product are you using here? Second, aren't you a little bit afraid of liver damage in this high dosing in a probably already damaged liver? So this would be my 2 questions.
Oui, merci beaucoup. Donc effectivement, dans notre essai, donc c'était pas un truc pour parler plus à la fin. Hein.
In our study, they were tablets of cannabidiol, which are dosed at 150 milligrams each. So there are 3 groups. One group of patients with 900 milligrams per day for 10 days during alcohol withdrawal. They shouldn't have any hepatic cytolysis, which is too high. And this is something which is monitored very closely. They have 3 liver tests at day 2, day 5, and day 10. So there's another group at 450 milligrams and one at placebo. So, but it's just 10 days to limit manifestations of withdrawal and anxiety and so on. We hope that they're going to be requiring less benzodiazepine during withdrawal, and for sleep, we can study that over that very short period. But we have had some 20 patients in the studies. Nobody increased their hepatic enzymes, but this is something which we're monitoring very closely. So we don't yet know exactly what the result is. Thank you very much for this presentation. I just had a question about the target variables to assess the impact. The question of the target population, that's always a question. Is it any patients with alcohol addiction Or is it particular profiles that are more severe? Do you have any hypotheses? Or in your trials, did you target a particular profile? As we are administering high doses in the trial that I'm carried out in alcohol use disorder, these are patients that shouldn't have too many medical complications. No cytolysis, or not too high. 3 times the normal is the maximum. These are patients who can also agree to be hospitalized. So patients who have slight use disorders don't want to go into hospital and have a lot of blood tests and so on. They don't want to do that. So that selects the patients to a certain extent of severe intensity use disorders who agree to be hospitalized. Thank you very much. I think we'll stop there. Thank you very much, Florence.
Yes, just after. Et on accueille, après Florence, le professeur Nicolas LINTZERIS de l'université de Sydney. Qu'est-ce que c'est? Ah non, c'est toi après?
Yeah.
Ouais, non, oui, non, c'est bon. It's okay, it's you.
Okay.
You will have the floor. Et donc, qui est un spécialiste, médecin psychiatre à la lithologie, oui, qui est bien connu en France, on connaît bien en France, qu'on voit souvent dans les congrès français, ATHS, Albatros, qui est bien connu pour tout ce qui est recherche clinique sur l'addiction aux opioïdes, mais qui a aussi beaucoup travaillé ces dernières années sur l'addiction au cannabis, sur le cannabis médical, puisque l'Australie a mis en place des programmes d'accès au cannabis médical depuis plusieurs années. Et Nick a travaillé sur le cannabis médical dans le cadre de programmes de recherche. Et donc je tiens à le remercier et d'avoir voulu bien parler pour cette session. Et for the first time, you will now talk about Buvidal.
Yes.
Today it's medicinal cannabis. Thank you, Nick.
Thank you. It's a great honour. Thank you for being invited here. It's my first time in Biarritz, and it's a long way to come here, but it was worth the travel. I'm going to be talking about medical cannabis or medicinal cannabis and the issue of cannabis use disorder. I want to look at 2 things. The first issue is the development of cannabis use disorder in patients who are treated with medical cannabis for other conditions, for pain, for mental health issues. So patients being treated with medical cannabis who develop cannabis use disorder and what the implications are there about how we think about medical cannabis. And then also, time permits, look at what we're doing about using medicinal cannabis to treat cannabis use disorder. So 2 different dimensions to this question. I also just need to say I have no conflicts of interest with any medical cannabis companies. I've not received any funding from medical cannabis companies. This is a picture many of you will have seen before. It was covered previously. I won't go through it. We have an endocannabinoid system. This is a oversimplistic fantasy. We do not really understand how the endocannabinoid system works. We have receptors, they're all over our body. We have more CB1 receptors in our brain than any other receptor system, yet we don't really know what they do. We have endogenous cannabinoids, we make our own cannabinoids, and then we have enzyme systems that break down the cannabinoids. So you can target different things here. You can give patients cannabinoids, but there's also some medications which actually look at the reuptake inhibitors. So there's lots of ways of modifying the cannabinoid system. Now, of course, the easiest way to modify the cannabinoid system is to give people cannabinoids. And we have 2 types of exogenous cannabinoids, plant and synthetic cannabinoids. The two cannabinoids I'm going to mainly spend most of my time talking about is THC and CBD. In an audience like this, most of you will know what THC does. It's the thing that gets people intoxicated when they use cannabis. It is a partial agonist at the CB1 receptor, which explains why your patients, when you're talking to them, and you can ask them, so you've just had 5 bongs or 6 bongs of cannabis. Does the 7th bong make you more intoxicated? And most patients will go, actually, no, not really. So THC is a partial agonist. You get ceiling effects. And it can do tolerance, it can do withdrawal, it does all the things that we're familiar with addiction. Not much to worry about when it comes to drug-drug interactions. Cannabidiol, in Australia, it is what we call a Scheduled 4 medication. In Australia, cannabidiol is only available on prescription by a doctor. You cannot buy it from a health food store or from a tobacconist. So in Australia, THC and CBD are prescription-only medications. There is a whole world of cannabinoids out there. There's hundreds of cannabinoids, and they all have these funny letters, CBG, CBN, the list goes on. We do not know what most of those do. So we're still trying to understand, what does CBG on its own do? This has led some researchers to talk about the entourage effect, that it's not about individual cannabinoids, but it's when people use cannabis, it's the mix of all these cannabinoids and they all somehow impact upon each other. Very difficult to research from a scientific perspective. So I think it's fair to say that our focus is on CBD and THC, and we'll leave the other cannabinoids alone for now. Let me tell you about what happens in Australia. Australians love their drugs, always have, and we love using cannabis. So this is a household survey. 40% of Australians say they have ever used cannabis. 12% said they used it in the last 12 months. For the first time, though, in our household surveys, they started asking people, why do you use your cannabis? And of the 12%, almost 9% said never for medical reasons. 2% sometimes medical, sometimes non-medical, and 1% only medical. So you can back calculate. Australia has about 25 million people, so we can estimate about 2.5 million Australians used cannabis last year, and we can estimate about 1 million Australians used cannabis for medical reasons. Now, this comes from household surveys. Only 1/3 of those people that said that they're using it for medical reasons had it prescribed. So 2/3 who say, I'm using cannabis for medical reasons, are still using illicit cannabis. What do I mean in Australia by had it prescribed? We have a very unique situation in Australia about how we regulate medical cannabis. So for almost 10 years now, doctors in Australia have been able to prescribe medicinal cannabis, and we use this for, there's a regulatory system which is designed for drugs for compassionate access. So these medicines are actually not licensed like normal medicines. So we have to use this funny mechanism to be able to access the drug. You have to go onto a website and enter some details. It doesn't take long, but it's an unusual system. And what it means is these are not licensed medicines, which means they are not licensed for any clinical indication. There is no dose linked to it. So it's not like a normal medicine where you get regulated, where the drug company says, I want to register sertraline for treating, an antidepressant for treating depression. In Australia, these are just medicines, and doctors can pick and choose what they're prescribing for whatever reason they want. There is no restriction. So you can use it to treat pain, anxiety, curly hair, grey hair, ingrown toenails, whatever you want. As a doctor, you can prescribe it. There is no training, there is no credentialing. Any doctor can do this, but the doctor must write a normal prescription. So the prescription says what cannabis product, what dose, how much, and how to use it. This is not the American model where you just go to the dispensary and ask the guy with the ponytail, what should I use? And then you just buy whatever you want. No, in Australia, it's like a medicine. We have over 1,000 products, and it varies from flower, so cannabis flower, which in Australia, 28 grams of a high potent THC flower, say 25% THC flower, costs around $200. On the black market, it costs $300. So it is cheaper on prescription than it is illicit, and the quality is much better quality. So what this means is that we've seen this huge increase in the number of patients being prescribed medicinal cannabis in Australia over the last, really since COVID. And COVID did a couple of things. One, people stayed inside and started getting stoned more. That was one thing. But the other thing is also, COVID led to the introduction of telehealth, and also business people came in and saw the business opportunity. And so we've seen this huge growth of private medical cannabis clinics operating on telehealth. And these are business-driven. Their objective is to sell more cannabis, not to treat patients. So that has distorted the treatment system a lot. It's also mean we've now got over 1 million Australians have been prescribed. We don't know exactly how many, probably 500,000 at any point in time. And this is leading a lot of concerns in Australia from regulators and from some medical authorities that this is not real medicine. This is just pseudo-legalisation, that there is no basis for medical cannabis. This is all nonsense and we have to stop it. So those voices are now starting to come through. So what is it that what are we treating? So this is some surveys, data that we've been doing now for the last 10 years. And you can see by far the most common reason is chronic pain, followed by a range of mental health conditions, mainly anxiety and depression in the mental health, and then some of these other things. Now, when they introduced medical cannabis, a lot of the regulators thought, oh, well, it's going to be for cancer patients or multiple sclerosis patients. I don't think they were expecting this huge growth in sleep, pain, and mental health. So what's the evidence for medical cannabis to treat? Well, we've got licensed CBD for pediatric epilepsy. We have nabiximols, which is a THC CBD for multiple sclerosis. That's it. They're the only drugs that we have licensed in Australia. Everything else, they're unlicensed, and it's fair to say that the evidence is variable. For some things we have okay evidence, such as pain. For other areas, the evidence, say, for THC, for treating anxiety, is very poor, almost non-existent, and indeed, some people have said it's contraindicated based on the few studies that have been done. The evidence is poor for lots of reasons, mainly because the studies are not very good. So a good example, CBD research. We have a whole bunch of studies that in the early days were looking at 30 milligram doses of CBD. Most of us now realise that anything less than about 200 to 300 milligrams of CBD, it's probably a placebo homeopathic. We don't know what it is, but you're not getting a real signal. So you can see the problems if you're pulling data from studies that are using 600 milligrams of CBD, an effective dose, and you pull that with studies that are using 30 milligrams of CBD. Hard to get a consistent signal. The other big problem is how we interpret the evidence. So you look at the pain field where there's a lot of research done, and if you go and get groups of doctors and you ask them, what do you think of the evidence for pain? The doctors say, it's no good, does not support it. If you go and get an interdisciplinary panel, so there's doctors and social workers and psychologists and consumers, they look at the same evidence and come up with different interpretation. So it's not just that the evidence is poor, it's how we interpret the evidence is also very debated in this field, very debated. And then from a clinician perspective, if you're the doctor, you're a GP, and your patient comes in and you're prescribing medical cannabis, and the patient comes back and says, "Doctor, I'm so much better. Look, I can walk again." Do you care what the randomized trials say? My patient is so much better. What does it matter if there's studies or not? And that's how consumers feel. What do I care if you've got RCTs? What does that make difference to me? I take the medication, I'm feeling better. For me, it works. So you can see that we've got this problem with evidence in this field. I better hurry up. The other thing we need to appreciate is the problems of comorbidities and substance use disorders. The most common reasons we prescribe medical cannabis, THC, pain, mental health, and sleep. We know the overlap with substance use disorder comorbidities are huge. So we often will have patients come in to see their doctor saying, "Doctor, I've been using cannabis for the last 10 years. If I don't have any cannabis, I can't sleep. So the cannabis is treating my sleep problem." Maybe. Or, "I've been using cannabis every day for the last 10 years, and if I don't have any cannabis, I get anxious. So the cannabis is treating my anxiety." Maybe. It could just be your withdrawal, though. It'd be like a patient coming along and saying to the doctor, "Doctor, I've been taking Valium every day for the last 10 years, and if I cannot have any Valium, I can't sleep." Is what's cause, what's effect? Very difficult to disentangle this. And in the world of most of the research, any patient with a substance use disorder is largely excluded from all clinical trials. So very difficult to understand what's going on here. Are we really treating anxiety or sleep, or are we treating an underlying cannabis use disorder? And let's not forget, no patient and no doctor wants a diagnosis of addiction. Only addiction doctors like diagnoses of addiction. So most GPs will not diagnose addiction in their patient, and most patients do not want to be called a drug addict. So you can see why we're doing a lot of treatment, but we're not calling it treatment of cannabis use disorder. So what's the data? Can you get cannabis use disorder for people using medical cannabis? Well, the research from, this is the data from sort of recreational or non-medical cannabis use. This is the sort of across all the studies over many years, 10% of people that use cannabis in the last year meet a diagnosis of cannabis dependence, roughly. That's kind of the... What we're finding is much higher rates in medical cannabis patients. We're seeing this not just in Australia, but in the US, in other countries where they're trying to do this work. You can see here, this is using any cannabis use disorder, so that's the 2 criteria or more. 43% of patients using medical cannabis met criteria for a cannabis use disorder, and importantly, 17% met a moderate severe, which we call dependence. So that's almost 1 in 5 patients. And then you can see the difference if it was illicit cannabis or prescribed. So lower rates in the prescribed, but still very, very high. 15% of patients prescribed. And these are patients being prescribed for pain, for sleep, for anxiety, for depression. What's interesting is the criteria, 50% of patients meet criteria for a cannabis withdrawal syndrome. 29% endorse tolerance, 25% cravings, 20% using longer than they hoped, and 16% recurring situational harm, which means driving. Very few patients were endorsing harms associated to cannabis. the psychological, the physical, the social harms. So this is a different flavour to dependence or use disorder than if we were looking at alcohol, opiates, cocaine, amphetamines, we'd be seeing a different profile of endorsement. Now, this has led some people to say, if the cannabis is being prescribed, you should not include tolerance and withdrawal. So you know how with prescription opiate use disorder, we take those out? So there's a debate happening, are we over-diagnosing dependence? But that's a debate for the future. Look, these are the factors associated with it. It's all in the paper. You can look this up. In a nutshell, people with worse mental health, people using cannabis for non-medical reasons, and people using THC were more likely to have dependence. So I'm a little bit concerned that basically within the medical cannabis community, cannabis use disorder is not really being taken seriously. The kinds of things I hear all the time, cannabis is a safe drug, can't get harms. Addiction does not happen in good patients, only bad patients. Remember this? Because this is what all the pain doctors told us for 20 years. You cannot get opiate addiction in my pain patients. It's bad people get addiction. My patients are getting medication. And then the other thing that happens in medical cannabis is this personalised treatment, which is, look, we leave it up to each patient to select the dose. That's fine, but not if you've got addiction, not if you've got cannabis use disorder. It'd be like saying to a methadone patient, look, here's the bottle of methadone. Have as much as you think you need. We would not be comfortable with that. Many of the people doing the medical cannabis, working in these private clinics, they're not experienced in prescribing drugs of dependence, or they ignore it. So my concern is what we're seeing with medical cannabis is the exact same problem that we saw with opioids, with benzodiazepines, and that we're seeing now with stimulants for ADHD, which is that medicine is blind to the issues of addiction that can happen with the medications we prescribe. And this is why I think it's important for addiction medicine and addiction psychiatrists to be involved in this discussion about how we use medicinal cannabis, because we have to apply the same principles of safe prescribing, the same way we think about how to prescribe benzodiazepines and opioids safely need to be thought about in medicinal cannabis. And this model where patients can just use as much as they want is a recipe for problems. Anyway, so that's the issue of cannabis use disorder in cannabis patients. I just want to quickly talk about this issue of, can we use medical cannabis to treat cannabis use disorder? There's been lots of systematic reviews. Most of them are really problematic and flawed, and I won't go into them. This, though, was the volume, I can't pronounce it, reviewed from 22. It was probably the best summary of the trials looking for cannabis use disorder. And so you can look that up. They included some studies using dronabinol and nabilone, which I won't talk about. They're synthetic THC products outside of America, rarely used. I don't think they're even used much in America anymore. So why do we need medicine? Why do we need new treatments? Well, basically, what have we got to treat cannabis use disorder? We've got counselling, we have self-help and withdrawal. They're fine, but most patients don't do well with these approaches. So, like most areas of addiction, if we can link a medication to counselling, we're probably going to get better outcomes than medication alone or counselling alone. So, can we use medications to combine with counselling to treat cannabis use disorder? This should never just be about a drug, about a pill. CBD. So there's been a lot of interest in using CBD for cannabis use disorder. Case reports go back now 30 years. And some of the biggest literature comes from here in France. And that's because of your availability here of over-the-counter CBD products. So there's some consumer reports. A small case series has been done from Clerac, who I believe is in the south of France, yeah? Is he in Bordeaux now? Excellent. Ah, good. So, and I know that they've got a CBD study about to start. The first real investigation was done by Freeman and colleagues in the UK, and they showed that 200 milligrams of CBD was no better than placebo, and that 400 and 800 milligrams had a signal. This has led us to do a study which we've just finished. So we recruited 253 patients. It was a 12-week study, 400 milligrams of CBD versus placebo. Everyone got 4 sessions of CBT. The last data entry is happening this week. We hope to have results out early next year. We haven't broken the blind yet. And what's exciting is that I believe that there is a study here in France which is also looking to replicate this, but with inhaled products, and that there is a study in Canada also about to start looking at CBD. So there's a number of proper randomised controlled trials. So I suspect within a year or two, we should have some signals about is there a role for CBD for treating cannabis use disorder. But the real interest is always going to be in THC. Now, we've done 2 randomised controlled trials with nabiximols, and also the Canadians have published a pilot study. But I'll present our work because I can, and they were properly powered. The first study did was a simple little inpatient detox study. Placebo versus CBD, double blind. You can see we gave doses of nabiximols for the first few days. They're quite high doses, by the way. That's 18 milligrams of THC. That's a big dose of THC. And then the dose tapered down, and you can see what happened. Less withdrawal severity in patients who got the nabiximols compared to placebo, and more patients finished the detox. So that made us think, well, fewer symptoms, better completion, that's a good outcome for withdrawal. We followed patients up a month later, no difference between placebo and Sativex. That does not mean it's a bad detox drug. It just tells us that people with addiction relapse. If we did a study of Valium for alcohol withdrawal, we would see the same thing. Valium, fewer symptoms, more people finish, but you follow patients up a month later, no difference in Valium or placebo. So it tells us it's a useful medication, just do not expect too much out of detox, that's all. So what we say, what role of THC medicines? Consider that you may want to use tapering doses for a short period of time, 7 to 10 days maybe, up to 50 milligrams. I would only, though, really think about it as those patients who describe problems getting through cannabis withdrawal. And not every patient does. It's actually a minority who will say, I can't get through withdrawal. And they're the ones you might want to think about using it for. But remember, withdrawal is not just about medication. You still need the daily support, the counselling, the monitoring, really important. But most patients return to using cannabis. So what did we do? We then thought, let's set up the longer study. And this was a 12-week randomised controlled trial of Sativex, the nabiximols, versus placebo and CBT in both groups. What we saw was less illicit cannabis use in the nabiximols arm, which is what we expected. But what was really interesting, when we followed patients 3 months after stopping the medication, the nabiximols group was using less cannabis than the placebo arm. So this made us think, this might be like a nicotine replacement treatment. You don't necessarily have to keep it going forever and ever and ever. So this may be more NRT than methadone maintenance in terms of the treatment paradigm. So what Roll basically would say, look, what I say is use a step care approach. Most patients stop using cannabis without ever coming and seeing a doctor or a counsellor. And that's great. If you can stop on your own, stop on your own. If you can't stop on your own, then think about a detox or getting some counselling or some self-help. And if that works, good for you. But if that doesn't work, that's when you may want to think about introducing the role of a medication. And whether or not you're going to use a nicotine model, you know, an 8-week, 12-week, or a longer-term maintenance model really depends on how well the patient goes. So my advice would be stabilise the patient, try to bring the dose down. If the patient is relapsing and not doing well, keep the medication going. It's not that hard. Now, of course, there's a lot of critics that are saying, you're just swapping, you know, one drug for another. You're just become a drug dealer. That's all you are now. I started working in this field 35 years ago, and this is what everyone used to tell me when I said I prescribe methadone. It's just another opiate. You're just a drug dealer. You're just a legal drug dealer. You're just swapping one opiate for another. So what's the rationale? Think about this. If we can get, so first and foremost, 2/3 of our patients, when we ask them, what do you want to do about your cannabis use? 2/3 of them say, I don't want to stop, I just want to reduce and I want to get it under control. 1/3 say, I want to stop altogether. So there's a lot of patients out there that are not saying I want to stop, they just want to get out of this addiction that they have, of feeling that they have to get up in the morning and they can't go to work without having a joint or a cone. They want to get their drug use under control again. So why we think that this is actually legitimate medicine is, one, we can prescribe safer products. So oral products, for example, rather than using flower or inhaled products. Safer routes of administration. We can shift client goals over time. So patients are usually coming in using 2, 3, 4 grams of cannabis a day. Over time, you can actually reduce that down, especially if you convert them to oral THC products as well. That's when you see big changes. It overcomes problems of prohibition and stigma for many of our patients, and importantly, you engage the patients in healthcare, because most of these people are 28-year-old young men. 28-year-old young men do not go to the doctor for other things. So this is a way of engaging that population. But if all you're going to do is a 5-minute consultation every 3 months and prescribe, here's 2 ounces of cannabis flower, well, yeah, then maybe all you are is just a legal drug dealer. So it's not about the medication, it's about how we deliver it and the context with which we work with the patient. Future research directions, we need replication studies. 1 RCT, 2 RCTs, not enough. We need more studies. And it's exciting that we're going to see more CBD work coming through. We need trials of oral THC for cannabis dependence. We don't have any trials of an oral product yet. There's a lot of interest, it's just been mentioned. We're about to start our own CBD trial and we're using, I think, 600 milligrams of CBD. There's a lot of interest in THC for opiate use disorder. Where does a lot of this come from? The animal work is positive. There's a lot of interactions between cannabinoids and opioids. And when you talk to a lot of our patients, you ask patients, how did you jump off methadone? And people say, I got an ounce of cannabis, I went to the farm, and I locked myself up for 2 weeks. So this is something that many of our patients are aware of, that cannabis can help them cope with opiate withdrawal, but we have no clinical trials yet. And then the other thing we also need to appreciate is that most of the medical cannabis research has excluded patients who have a substance use disorder. So if they're already a regular cannabis user or they have an opiate use disorder, most of those patients are excluded from trials. So it's, for our patient population, it's almost as though we have to start that whole evidence. And to that, we are about to start a study in collaboration with the University of Bordeaux and with Grenoble, where we're looking at different medical cannabis products for chronic low back pain in patients with opioid dependence. specifically. So it's a sort of like a replication, but in opiate-dependent patients. On that, I'll stop. Probably went over time, under time? Oh, good. Thank you.
Thank you.
Thank you very much.
Presentation. Any question for the LINTZERIS? Maybe 2 questions.
Bonjour, Karima Kouba, Toulouse, médecin addicto. En fait, je voulais savoir si dans ces études, il y avait des observations par rapport aux addictions comportementales, et notamment les, pas traduction, et les troubles du comportement alimentaire, par exemple. S'il y avait des données positives sur les addictions comportementales.
Can they repeat the question, please? Can the person repeat the question?
Can you repeat the question?
I want to know if in these studies there are any observations concerning addiction, behavioural addictions, whether screens, gambling, or eating disorders, or if it was just simply about products.
Thank you. That's a really interesting question. I was talking to someone just the other day about this, about what do we know about the interaction between some of the behavioural addictions, like gaming disorder in particular, and cannabis use disorder, and there's very little crossover research has been done yet. We did not look at behavioural addictions in our most... We've screened for PTSD, for anxiety, for all these screens, but we never thought to screen for behavioural addictions. So the next studies, maybe we need to do that, yes. But again, there's potential for CBD with some of its anti-craving, anti-anxiety effects. Maybe that might have a role. But I haven't seen any studies yet for behavioural addictions with medicinal cannabis. But I think that's a really important area to look at.
Second question. Maybe I have one question for you. What do you think? Oh, sorry. What do you think about an association of THC and nicotine? Because a lot of people, most of people who use cannabis use at the same time nicotine.
So, in our CBD study, we found nicotine replacement. And what we had to do, because this is a big thing, that for a lot of our patients in Australia, cannabis is usually mixed with tobacco. I know in some countries it's cannabis only, like in Argentina and stuff, Brazil, cannabis only. In Australia, they mix it with tobacco a lot. It's the norm. So if we had to use a lot of nicotine replacement therapy in both the CBD and the placebo arms. It was a blinded study, we did not know what. And so we were doing everything from, it depended a lot on how the patient described using their cannabis, whether or not we were using patches, lozenges, sprays, gum, all of them. So I think, off the top, it's over 40% of patients got nicotine replacement therapy during the study. But again, we haven't broken the blind, so that data will change. Yeah.
Thank you.
But it's really important that if your patient uses cannabis with tobacco and they want to change their cannabis use, you have to think about the tobacco.
Yes.
Because a lot of the hit that they get when they pull a cone or have a joint, a lot of that's nicotine. The immediate effect when you have a bong or a joint is nicotine, not cannabis. Cannabis takes about 5 minutes before you're getting peak plasma levels. It's the nicotine which causes that initial rush. So that reinforcement is as much nicotine as it is cannabis. So we have to pay attention to both.
Thank you. Thank you, Nick, for this presentation. Thank you very much.
Thank you very much. We now have the great pleasure to welcome Jean-Michel DELILE, who's a psychiatrist and addictologist that we don't need to introduce, who's also chair of the Scientific Council of the Addiction Federation. And also, I've known you for some time also, as I've taken part in the AFSAPS and ANSM drug trials in the psychotropic and other drugs disorders. You also taken part in the Scientific Council that was set up by the Mayor of Bègle on the experimental deregulation of cannabis. I'm very happy to ask you to talk about the benefits and risks of cannabis-based medicines for mental disorders. Thank you very much, Nathalie, and thank you very much, Nicolas, for your invitation, and also thank you to ATHS. I have a little less merit than Nicolas. I've come from a lot nearer than Nick. I've just come from Bordeaux. The presentation I'm going to show you now is more encouraging than what we saw on cannabis use disorders. There are some promising areas, but here in mental disorders, the data is much less encouraging. That's the least you can say. I could almost look at just the first 3 slides, because this is something I presented to the Addiction Federation as part of the Medical Cannabis Monitoring Survey, and I looked at the possible extensions of indication, and particularly in psychiatry, and in particular in the treatment of addiction. I'll go directly to the conclusion that we talked about in the scientific committee. The conclusion: the risks and the benefit risk appears controversial in certain psychiatric indications, particularly in certain US states, anxiety disorders, post-traumatic stress disorder, and even clearly unfavorable in the context of depression, bipolar disorder, and obviously psychotic disorders. So what I'm going to present is about the same thing, but as Florence said a moment ago, this needs to be updated, but the data actually goes in the same direction. However, we were more optimistic, that's not the subject, but this has just been mentioned a moment ago, on the possible use of cannabinoids in the treatment of use disorders in general, as Florence showed, and particularly the use of cannabis, as you've just seen a moment ago. We also said at the time that we could getting some encouraging data on CBD use for psychotic indications with preliminary studies which were encouraging, and at the time Piazza had been to ATHS very often. We began working on modulators of CB1R, new prospects for CB1R, with allosteric modulators and so on. But now, the recent studies are actually reinforcing these opinions. So I'll go rapidly over receptors. You saw a moment ago that THC acts on CB1 and CB2 receptors, and CBD acts also on the TRP receptors, which modulate the antagonists and the action of THC on the CB1 receptors. And this explains in part what we're going to be seeing soon. The drugs that were used most in the experiments, as we said a moment ago, there's a synthetic cannabinoids, and nabilone and cannabidiol, and dronabinol, and a number of other studies of the kind that we've just seen. We go to beginning. I had a list, and Nicolas gave me a list. Nick gave me a list of psychiatric disorders, psychotic disorders, bipolar disorders, and then indications in which users administer their own cannabis to deal with anxiety and depression and post-traumatic stress disorders. There has been a review of the literature which resumes the situation. That was the review published by Black in the Lancet, which connected the studies, the eligible studies, some randomized controlled studies for depression, anxiety, and for attention disorders, for post-traumatic stress disorder and psychosis. The conclusions were that THC, pharmaceutical THC with or without CBD, improved anxiety symptoms in people with other conditions, mainly chronic non-cancer pain and multiple sclerosis. but with a very low level of evidence. And we're going to see that. These are the only areas where it appears that there is a use when anxiety is comorbid with a main disorder of chronic pain. And the hypothesis could be that the soothing of the chronic pain is going to have a beneficial effect on the anxiety or depression without necessarily having a direct interaction with the psychological problems. But this is an area for us in which the data is rather favorable, even if the level of evidence is quite low. It also can have an effect on sleep disorders. But pharmaceutical THC, with or without CBD, tended to worsen the negative symptoms of psychotic disorders. We also see that it tends to amplify the severity and frequency of maniac behavior in psychotic disorders. And pharmaceutical THC, with or without CBD, had no significant effect on other primary outcomes of the mental disorders that were examined. The next sentence, I think, is important. This indication increased the number of people experiencing adverse events and withdrawal syndromes. This is what was mentioned a moment ago. And this means that there are far more undesirable results than in the placebo groups. And few randomized clinical trials that examined the role of pharmaceutical CBD. I'm going to go quickly over psychotic disorders. This is an article I published in Psychotrope. It's very easy to get. When we try and look in the study what the elements, environmental elements are, which can play a role in the risk of developing schizophrenia, you can see that what had been listed were obstetrical complications, winter birth, sometimes childhood trauma, living in cities, first-generation migration, and you can see that the environmental factor that has the most weight is 5, it's considerable, that is cannabis use. There were meta-analysis that confirms this data. They're fairly old. A lot of the studies that had us thinking, the Swedish studies, as other studies from New Zealand, showing an excess risk of developing psychotic disorders on cannabis users. And the interesting thing is that the more the cannabis use is high, the greater the risk of developing a psychotic disorder. So we know that when we have cause and effect relationships, this leads to a presumption of elements. It's not just basic correlation. So that you can see that this is Marconi's fine work on the fact that high consumption of cannabis is linked with an significantly increased risk of developing psychotic disorders and with symptom levels which are more intense. So these are points that need to be taken into account. And this is what you see as a summary. You can see the best known studies, Zammit and others. You can see the greater the exposure to cannabis, the greater the risk of developing psychotic disorders with dose-related effects. The exposure to cannabis often means that people who are going to be developing psychotic disorders do this earlier. The onset is earlier than those who haven't used cannabis, with a standard deviation of 3 years. You know that the earlier you start, the less good the prognosis is. There is no links with other substances, and a certain number of cohorts show that there are also going to be problems of observance. On the evolution of use disorders, we can see that there are associated disorders. The interesting indirect effect is on depression and anxiety, because people have psychotic disorders. Cannabis increases comorbidity with possible depression and anxiety. In a meta-analysis studying prognosis of patients, the relapses and rehospitalizations, when there's a psychotic disorder which is pre-existing with minimum follow-up of a good length of time, show that if people stop using cannabis or continue using cannabis, the prognosis is not going to the same. You can see this isn't perhaps not very clear, but you can look at the slides that I would be happy to leave with you. We can realize that the risk of relapse is higher when people continue to use cannabis with regard to those who didn't. And on this next slide, the interesting thing is that at the top you can compare people who have used with those compared to those who are not cannabis users. Here we can compare people who used cannabis but stopped, they'd withdrawn, and they realized that they were developing psychotic disorders, so they stopped cannabis. We have a reduction of the effects. But the interesting thing is that if you look at those people who stopped and compare those to those who have never been users, those who stopped recover a risk of relapse which is comparable to those who had never used cannabis. So this is one of the interesting practical elements to give certain orientations as to what we can do. A few interesting avenues to explore with regard to CBD, 1,000 milligrams per day, with a reduction of the levels of severity of the psychotic disorder. This was a study that was encouraging, and I could see the evolution which was much more favorable in the cannabis group than in the placebo group, but this was associated with psychotic treatment. This was an adjunctive therapy, as we say, and in terms of overall improvement, it was shown that people who had benefited from CBD felt that they were much better than the other subjects in the study. But you have studies which haven't confirmed these preliminary results, so this is something that needs to be followed up. It's a promising avenue, but there are some recent studies which I think are interesting and have just come out, which were carried out, and I think this will be of interest, in people who were comorbid. They had a psychotic disorder and cannabis use disorder. And the hypothesis was that if they didn't stop taking cannabis, if they had intensification of the positive symptoms, did CBD reduce the intensity of the psychotic symptoms in these people? And the result was no, there's no difference between the placebo group and the CBD group. The interesting thing is when you look at what happens here on the positive symptoms, and these are negative symptoms, when you look at people who are consuming THC, you have an effect which is going to be perceived by the subject as strengthening. But then if you look at the deviation between the CBD group and the placebo group, there's not very much deviation. So this, unfortunately, is a study which suggests that you need further work. In bipolar disorders, it's almost comparable, except that here there's less of a cause and effect logic, but aggravation of the prognosis with an element which is fairly clearly established. That is that the consumption of cannabis tends to increase the risk of developing manic symptoms, and particularly to make them more intense and more deleterious. We know that with regard to bipolar patients, the recurrence of manic symptoms is a factor of intensification of the chronic development of the disorder. Some studies suggest that cannabis users risk to develop bipolar disorders earlier than those who didn't use cannabis. And another thing that is well known is that cannabis independently aggravates the risk of suicide in this context. Another element which is interesting and it's positive, as I said about schizophrenia, it showed that after stopping using cannabis, patients regained the same levels as those who had never used cannabis. And now we're going to go into rather more complex zones, as has been mentioned a number of times, with data which are equivocal, but it's important to bear them in mind because they're often the reasons why people say that they consume cannabis themselves, to soothe their anxiety, to sleep better, to ease possible depressive effects. So there have been some longitudinal studies showing that some contradictory results, as everybody has said, sometimes fairly weak effects with correlation effects which are probably bidirectional. In other words, the depression, meaning that you're looking for drug consumption and can have an effect on cannabis use, or increased cannabis use can have an effect on depression. 3 studies suggested no difference between cannabinoids and placebo on the course of depression, and there were different doses that were used with a negative effect, despite the relatively high quantities going up to 11 to 14 sprays per day. And there was no clear difference between the 2 groups. It would appear, moreover, and that's Van Lau, that regular use of cannabis slightly increases the risk of subsequent depressive episodes. The risk, including suicide ideation and suicide attempts, appears to be greater if consumption occurred early, and that's fairly classic. And meta-analysis done by Levran suggests a possible dose effect. But whatever the situation, the data is much more fragile, and the current state of the situation doesn't mean that we can conclude. For anxiety disorders, this is even more complex, if I could say so, for the same reasons. Obviously, the question is anxiety leading to cannabis or cannabis leading to anxiety? Of course, when you are working in a field like mine, where I've seen hundreds of people who've come to consult for problems linked to cannabis and who had cannabis use disorders, almost all of them mentioned an increase of panic problems, for example, panic attacks, social difficulties, panics in the bus, in the tramway, and so on. But they also said that it helped them in the short term to soothe their anxiety, and it helped them to sleep. So it's obviously very complicated. I think one of the things that has been suggested with regard to sleep and perhaps anxiety is that they're dependent. When they go to withdrawal, they have problems of anxiety and sleep. So in the short term, they're going to note that taking the substances is going to soothe them, but it soothes them from the dependence. So the chronic intoxication can have relatively negative effects. It would seem that the THC-CBD ratios tend to have an increased effect on anxiety scores. But again, this is a point of view which is rather fragile. The areas of anxiety and CBD donor were perhaps easier to note in a context which is particular, which was people speaking in public for conferences, for example, in ATHS or something like that. 600 milligrams might help. You can also ask oneself whether social phobias and the experience of addictology are predictive of moving to addiction when you have use disorder, because soothing is also something which encourages relapse, and we can see that the social environment is a predictor of dependence. And the first panic attacks were very often followed intoxication. So the hypothesis according to which the nature of anxious attacks and the omnidirectional dimension is perhaps questionable. But the key element, and there's a relative consensus, that is on the data on anxiety. Cannabis does seem to have an antalgic effect and can have an interesting effect. Whether it's dronabinol, nebulinon, or nabiximols, you have the references here. Another element, and I've stopped more or less with that, and that is post-traumatic stress disorder. There have been associations between PTSD and cannabis, which are frequent. We know, including in France, that we don't have so many veterans as in the United States, but a lot of veterans consume cannabis explicitly to try and reduce the nightmares and so on at night. So the associations are quite frequent. And if we, I think, carried out a survey on cannabis users who have comorbidity, the professionals would say that they need to be rather more reserved, because the major study of comorbidity indicates that adults with PTSD are 3 times more likely to, if they consume cannabis, those who consume cannabis are 3 times more likely to develop PTSD. The data, however, are contradictory, and it's not clear whether cannabis causes, exacerbates, or alleviates the symptoms of post-traumatic stress disorder. There is one element which needs to be taken into account, that is that cannabinoid receptors modulate the action of glucocorticoid hormones, which play a central role in the consolidation of traumatic memories. So this may be a very interesting avenue to explore. But for the moment, the things that we could look at in that area, there was a double-blind randomized trial on a low number of soldiers and showed a significant reduction in nightmares with regard to the placebo group. However, there were no other favorable evolutions. There was another study on more than 2,000 veterans in the States, where it was seen that cannabis use was significantly associated with increased severity of the symptoms of PTSD, violent behavior, and measures of alcohol and drug use compared to veterans who'd never used cannabis, or those who'd stopped using cannabis during the period of observation. Finally, There's a more recent double-blind crossover RCT of 80 participants suffering from PTSD, and they found no significant difference between the placebo and cannabis. So that's the question that was asked at the beginning. This is in AUTHIER's book, Cannabis pour les nuls. The question was for a lot of, is cannabis good for the mind? This is the question. And I drafted the part of that chapter in the book, and the conclusion is not really. Apart from chronic non-cancer pain or psychiatric disorders, among the most common reasons for medical cannabis and cannabinoid use, not only in Australia and so on in the States, but here. But the data are contradictory when it comes to depressive disorders, anxiety disorders, and PTSD, with many studies highlighting rather negative long-term effects, and even in the short term, it can have soothing effects, and the risk-benefit ratio is rather unfavorable. However, some very low-level evidence suggests that pharmaceutical TCH, with or without CBD, may lead to a slight improvement in anxiety symptoms in the context of general medical conditions or chronic pain. On the other hand, the robust data indicate that cannabis, THC, has a negative effect on psychotic disorders and no doubt on bipolar disorder through intensification of manic episodes. Conversely, CBD may have a beneficial effect on psychotic disorders, but the evidence remains contradictory. So our prospects, the outlook, you have to pursue research. A moment ago, we talked about the funding for various studies and the anti-addiction fund or whatever, so the use of CBD in withdrawal of cannabis. This is something which needs to be pursued because it certainly seems to be an interesting avenue. And again, publicity for the book, AUTHIER's book, and thank you very much for your attention. Thank you very much, Jean-Michel. I think that if the question was asked about setting this up experimentally for mental disorders, I think the answer would be the same. Not yet. We need to carry out further research. Well, sorry, I can't hear him. Where's the microphone? Yeah, that might have a negative effect, was the end of his sentence. I was just saying that the research, we need further research. That really is the essential thing. So are there any questions? I'm working on addictovigilance in Paris, and we're working on data on the Dromafo service base, and we carry out some requests on methylphenidates, and there was feedback from users which said that methylphenidate at times was something they couldn't deal with, and they preferred cannabis because it was good for them, it calmed them down, and I'd want to have your advice on cannabis and tada. Yes, of course, this was not the subject that I was asked to talk about. I was talking about mental disorders, but what we do know, to go very, very quickly over on this, is that the presenting when you're a child, if you have attentional disorders, that increases the risk of developing addiction in teenage years. That has been established, but if you can prescribe methylphenidate for children, is that going to reduce this risk? This is, I think, something which has been established beyond the direct benefits with regard to the attention deficit disorder. It can also be protective with regard to the risk of developing addiction. However, methylphenidate, which was originally prescribed as immediate release, is going to have effects which may be undesirable in terms of further anxiety, inner stress, as all stimulants. With some users, it's very fine with children, but as soon as you get to teenagers and young adults, everything becomes complicated because these are people who have a certain number of independence in terms of their movements. They try to correct the rather negative effects of stimulants, which is quite classic in our specialities in addictology, with products are going to be initially sedation products. But we know very clearly that cannabis is not very good for attention and concentration and memory and so on. The fact that initially people who can perceive a soothing, beneficial effect, which is a classic effect for years, people who have erectile dysfunction or pulmonary arterial hypertransition or whatever, that can have an effect on that. But if we know that as it's a disorder which is durable, if the use of cannabis is repeated and intensified, then it can risk to have a disorder, a use disorder, so they're going to have withdrawal effects and short-term complications such as disorders of memory and concentration and so on. So we need to be able to discuss this with people on the fact that even the experience is interesting, but this needs to be discussed with more clinical input and to perhaps temper the ideas, the impressions that you have. You might have short-term soothing and easing, but there can be a middle range, middle-term aggravation of the disorder. But I think I have specialists like Melina who are perhaps in a better position to respond. But as far as I remember, cannabis, the question is, do patients with these attention disorders, in the studies, which date back a few years now, cannabis emerged as a fairly often represented substance, and users reported a beneficial effect, not on the lack of attention symptoms, but on hyperactivity, motor hyperactivity, and so on. That's what you were saying. Internal attention and irritability. It began soothing them, and potentially there'd be effects on sleep and so on. So you could find some of the motivations that have been promoted overall with the self-administration of cannabis. Thank you very much. No more questions? Thank you very much. Jean-Michel.
Alors, donc, pour la dernière intervention.
Our last talk this afternoon, it's with great pleasure that we welcome Dr. Main Offray, who is head of the Lyon Regional Pharmacovigilance Unit and who has followed up pharmacovigilance and addictovigilance for the French experimentation of medical cannabis. I think this is what you're going to talk about in introduction. And for the French Medicine Agency, there's going to be a 5th report published in the near future about the adverse effects and addictovigilance of medical cannabis. And this work was carried out in collaboration with the CIEP in Lyon. And this follow-up was very close to the experiment. All the adverse effects were listed, and I will let you talk about this. Thank you for coming and working with us over the last few years. Thank you very much for the invitation. I'd like to talk about the adverse effects of medical cannabis because I've been working on this for 4 years. I've been following up experiments, and I do this with my colleague Chevalier, who is specialized in addictology. Perhaps not everybody is aware of this, but medical cannabis experimenting in France started in March 2021. It's extended until March 2026. It was only supposed to be for initial 2 years, but it's been extended for several reasons. It's experiment. It's not a clinical test, and the aim is to evaluate new health policies and the use of medical cannabis in France, how to make it available to patients, whether it's by a prescription in pharmacies or in hospitals, and also to collect the first French data on the efficiency and safety of its use within a medical environment. As Nathalie said, there's a register to list all the information about different patients, and this enables us to have quite an exhaustive list of the adverse effects. Just to give you some data, there were 5 indications for refractory pathologies. Neuropathic pains were the main case. Then this is followed by epilepsy, pharmacoresistant epilepsy, and certain symptoms in oncology. There were 3,209 patients. They were the ratio of TSH and CBD was there were 3. It was in the form of oil, in the form of essence to be vaporized. And we had 497 prescribing doctors in reference centres, and 1,413 pharmacists, whether in the pharmacy, in pharmacies or in the hospital environment. We looked at the adverse effects of medical cannabis. There are 2 main molecules, THC and CBD. As these are 2 different molecules, they have different actions, and so there's different results for each of them. We looked at there's a lot of data in the literature about the effects of medical cannabis. I've tried to include this here. There was a study in 2021 with a double blind test, bringing together all the natural and synthetic cannabinoids in patients at age 50 or over. And it was mainly THC studies. And only 4 studies evaluated CBD. So I'm going to talk more about the association of THC with CBD. There's no increase in serious adverse effects, and the combination. What's interesting is that there was no increase for serious adverse effects, and we could have thought that this would be the case. This study didn't find this, and there's no increase in the risk of death, which is reassuring. There's an increase on the incidence of certain adverse effects with THC, dry mouth, vertigo, trouble coordinating, falling asleep, and euphoria. And with the combination, as nausea, sleep, vomiting, dry mouth, vertigo, disorientation, fatigue, and visual troubles. So this depends as well on the presence or not of CBD. In this experiment, we looked at different adverse effects, especially cardiovascular. We haven't talked a lot about them, but it's something that's something important needs to be taken into account. We know that recreational cannabis users, the risk is increased. And this is carried out by a group of Toulouse pharmacologists based on observational studies. They included around 20 studies, just one about medical cannabis. Most of it was more about recreational cannabis. And we don't know the quantity of THC was present. Sometimes some of the patients have comorbidities, so it remains difficult to characterize. The authors found an increase in the risk of strokes by 2, and risk of mortality, cardiovascular mortality, can increase by 2. We were also worried about psychiatric disorders. We discussed these briefly. Everything to do with psychotropic, and in these experiments with medical cannabis, these patients were not included. We were also concerned about the risk of suicide and depression, and this is described in the literature. We had certain questions with the symptom of medical cannabis. In medicine interactions, we haven't talked a lot about this. CBD is an enzymatic limiter in strong doses, so there's a risk that it will combine with the medicines and it will change the structure, methadone especially. And we were also looked at disorders linked to the use of medical cannabis. There's about 37% of patients 37.5 patients had at least one adverse effect, 2.6 a serious one, 59.7% had adverse effects during titration, and 13.6 stopped medical cannabis because of an adverse effect. In the graph below, I haven't detailed everything, but you can the main adverse effects are neurological disorders, digestive disorders, and finally psychiatric disorders. And there were 5 indicators in this experiment, and we can see it's quite interesting that we had a prescription profile which is different for epilepsy. They were much younger. They often had they were children. And in epilepsy, it was only CBD that was prescribed, with an average doses of 400 micrograms per day, whereas with the other indicators, it was around 40 milligrams per day, with doses of THC which varied, and which could be higher for certain specificities. But the CBD doses are much lower than what was presented in the study about alcohol. That can be seen in the profile of for epilepsy. We have many more digestive disorders than with other indications. So it's a problematic or different with CBD. And what I said before was there are concerns. There are 6 coronary syndromes, acute coronary syndromes, in patients with THC. So sometimes it's just after increasing the doses of THC, but the average age of these patients was 70 years old, and they all had cardiovascular risk factors. So based on this data, it's hard to determine whether cannabis had acted as a trigger or not. So we need to carry out more in-depth studies on this, and that's what we're doing at the moment to better describe this risk. We also had suicidal thoughts in 8 cases, sometimes without THC, and people without physical psychiatric problems. And 50%, a lot of, and some patients might have found it less efficient or had extra disorders. And in terms of what they expected from the experiment, there was 1 case of hyperemesis, cavernous hyperemesis syndrome, and 1 case of acute pancreatitis. These patients we've documented the medical interactions. It's an ischemic inhibitor. It's an enzymatic inhibitor at the origin of overdoses of the medicine. It can cause interactions with anti-vitamin K and with an augmented INR. In terms of addictive vigilance, I went to present my colleague. There were just 12 things to evaluate. The main indicator was under events on the screen, we had case withdrawal after a period of experiment. There was no more medicines left in stock, and so it wasn't easy for patients to get hold of it. Cases of tolerance, and also the idea of flowers at home. And we had 2 cases of misuse of inflorescence based on THC, one for medical cannabis use. What was regrettable, there was no addictology records for these patients, and this makes future evaluations difficult. To conclude, what we find in the experimentation of medical cannabis in France compared to recreational cannabis, 2.6% of patients had an adverse effect. The additional evaluation is necessary for cardiovascular and psychiatric events, especially via pharmacoepidemiology. We have a national, quite a high-performance system in France. We need to better characterize these cardiovascular disorders. There's a risk of medical interactions. We talked about hepatitis before, but nevertheless the doses are quite small still. And finally, in terms of addictology, increased vigilance of patients on VHC, and with medical cannabis in France, we need to identify what it's for. Thank you. Thank you, Maureen. Are there any questions? Thank you very much for your presentation. It's very clear and very interesting. I had a question. What is the evaluation of the history? Did you try to screen consumption during the tests, especially of CBD consumption or tobacco, which could also explain the adverse effects? In the register, we didn't have this information on addictology, but what the doctor prescribed, they had these elements. We sometimes, in medical histories, we're able to have information about associated consumption, but not enough to draw any conclusions. We would like to. It's a generalization, but for the moment, as things are, we don't have robust enough data to do this. Talking about the generalization or the future generalization of medical cannabis, just to say that medical cannabis is now in the public in a public health policy. In 2024, it was introduced in the list of medicines in the Code of Public Health Care. What we are now waiting for is a decree and 2 ministerial orders, which will enable operators to register applications for marketing medical cannabis. It's not saying it's science fiction, but it was supposed to happen in the next few weeks. But as you said, there's been a lot of randomness in the experiments. And at the moment, perhaps the environment is not at its best for a new decree on medical cannabis and cannabis. But experimenting enables us to anticipate certain things and generalize medical cannabis. I'd just like to complete what's been said. there are interviews planned at the health authority. I'm not sure what I'm supposed to talk about these. It's not top secret. It's not for authorizations. It's to fix the prices, reimbursements, whether it's reimbursed or not. And the health system will provide its conclusions in the first quarter of 2026. So this will take us as far as we can go with our patients. This, it's extensions on experiments. But from March onwards, and from March onwards, it won't all be done. But we've started an extension period for 2026. And we hope that a decree will be issued. The agency authorizes the medicine, and then other institutions are working on pricing and reimbursement, but they are definite subjects that shouldn't be ignored. In terms of authorization, it's no longer than when we did, but it's not any easier either. The decree is going to enable the application to be made, and it will be complementary. This will enable France to do this, and it'll be the second one, which is for accompanying the decree, the French accompanying French production, because even medical cannabis. So we have this text that should be also be published, but this is not the case for the moment, and there are still around 1,000 patients who are being treated by medical cannabis and who shouldn't interrupt the treatment. Thank you.
Et merci aux 4 intervenants. Pardon, c'est très fort. Merci à vous.
Thank you, Florence. Thank you, Jean-Michel, Nick, for taking part and giving us this panoramic view of disorders of use. Thank you.
Et merci Nathalie.